All right, so this is our IR talk. It's just an introductory talk. Going to cover some general vocabulary words like what is a French. We're going to talk about some basic angiogram anatomy, and going to talk about stents briefly and IVC filters. So getting rolling here, let's start out with some anatomy first, and not just any anatomy, but vascular anatomy, and not just any vascular anatomy, but vascular anatomy shown on an angiogram. So most of you are probably used to looking at vascular anatomy on CTA or MRA, and depending on how much exposure you've had in the IR realm, you may get disorganized or discombobulated by looking at an angiogram. So we're going to go through some basic stuff. So first thing to figure out anytime you see one of these things is where the hell is a catheter parked? So you've got basically three choices when you're dealing with mesenteric stuff. You're either in the celiac, you're in the SMA, or on a rare occasion you're in the IMA. And those would be like, so if you have no idea, you should be able to figure it out. But if you have no idea, I would guess celiac first. If celiac's not a choice, then I would guess SMA. I would pick IMA last, just because the questions for an IMA injection are going to be, well, they're going to be hard, and it's just less common. So this is probably the most common. This is a celiac injection. I know that, because I can see organs sort of blush. There's a liver and a spleen over here. I also recognize the branching morphology of the celiac is sort of like that, as opposed to the SMA, which sort of, goes down, and it just looks different. So catheter's parked in the celiac, and we remember the celiac has three branches. It's got the left gastric, it's got the splenic, and then it has the hepatic. And then coming off the hepatic here, down, is the GDA. So if that's the left gastric, where's the right gastric? Well, the answer is it's variable. Usually off one of the hepatics. Who cares? You care because people who write multiple choice questions sometimes care, and you care secondarily because if you're going to do a Y90, you have to trash it so you don't reflux and burn a hole in the stomach. In other words, if you're trying to shoot poison into the liver, you want to not get poison in your bowel, so you would nail this, take this guy down, and then if you've got a left gastric, you'd want to take it out also so that you're not refluxing back into the stomach. Okay, so I mentioned that this is the hepatic, but let's be more specific because there's different names for the hepatic artery depending on where you're at, and of course they would make excellent distractors on multiple choice. So it has to do with the relationship of what's before and after this GDA, which was I showed this on the prior slide. So prior to it, it's the bigger one. The bigger one is the common one. And after it, it's the proper one. So it's more proper after it loses the takeoff of the GDA. So what about this guy? This is another hepatic, but this is different, right? So question number one, where's the catheter parked? Doesn't look like that celiac injection, right? So if it's not a celiac injection, what's our second guess? It's an SMA injection. All right, so this is what an SMA injection looks like. So we've got the hepatic coming off of the SMA. Now, there are two different terms that you will hear thrown around. One is replaced hepatic, and the other is accessory hepatic. So what's the difference between those two? Is there a difference? Yes, and they would make excellent distractors for each other. So a replaced hepatic is a substitute for the normal, which is absent. In other words, the hepatic does not come off the celiac, it comes off the SMA. An accessory hepatic is like a duplicated hepatic. It appears in addition to the normal, which is also present. All right, so let's talk about a collateral pathway between the SMA and the celiac. So what's this arrow pointing towards here? So This we said was a GDA, right? So what's this thing? Notice that it's coming across. It's going to sort of do this sweep right here. So this is the superior pancreatic duodenal. That one. All right, so let's just take a look at the cartoon world here. So orienting you, celiac, SMA, liver, spleen, GDA. And off the GDA, there's the superior pancreatic duodenal. And then off of the SMA, there's the inferior pancreatic duodenal. And they form a collateral pathway which has a loop over this way that's these pancreatic duodenal arcade. All right, so next case. So what is that right there? So we see the outline of the colon here, and this little vessel here is all the way on the margin. So this is the marginal artery of Drummond. Here's another mesenteric collateral pathway, so to draw this one out, whereas the marginal artery is all the way out here. We are going to talk about this one here, and what this is a collateral pathway between the SMA, which is the middle colic, and the IMA, which is the left colic. There. That is called the arc of Reelin, because it has a name, and because it sounds European, possibly French, that makes it high yield. All right, moving down. Where are we at here? So, iliac bifurcation, internal, external, and then we've got a vessel coming off here, that guy. He's an important person because he's going to help us decide what we're going to call this vessel here. It's going to change based on where stuff's coming off. So prior to the takeoff of the inferior epigastric, you're going to have the external iliac. After it, you're going to have the common femoral. And then after the profunda comes off, you're going to have this guy, SFA. All right, moving on down in the leg. So this is a runoff angiogram. We've got three vessels here. The first one that comes off is the anterior tibial. Most people can remember that. A is the first letter in the alphabet. A, anterior tibial. It's the first one that comes off. Now, getting the other two right is a little tricky, depending on your orientation. So the way to remember it is that the most medial artery is the one that runs behind your tibia. And you can reach down and palpate your medial malleolus, right? That artery there is your posterior tibial. The medial malleolus is it's part of your tibia, right? So that's the most medial portion. So that one's going to be coming off medial. So the other thing is that the anterior tibial is going to continue as the dorsal pedial artery. So that could be asked as well also. All right. All right, so next case, this is an arm. And just to orient you, thumb and fingers down here, armpit up here. So the first ones were coming down here. This is the brachial artery. And then it's going to bifurcate, and, the radial is going to be on the radial side, and the ulnar is going to be on the ulnar side. Well, which one's which? I can't see the bones. Well, the trick is to find the yellow arrow, the thing with the yellow arrow on it. There won't actually be a yellow arrow. The vessel that the yellow arrow is pointing towards, that is the intraosseous, and that usually comes off of the ulnar artery. So if you're having to pick between radial and ulnar, find the intraosseous, and that one is that's going to be your ulnar. The way that I remember that is, I see you, I see you, ulnar artery, and then the other one is the other one. Okay, so this is a typical way that things look here. Brachial, ulnar with interosseous, radial, continuing down into this anatomic snuff box here, right, where you can palpate that thing. But sometimes you get this. Well, what's that? This is a so-called high takeoff of a radial artery. It's seen about 5% of the time. It doesn't really mean anything, except it can be shown to you to trick you. A piece of trivia is that if you're doing radial access, which you can do, that it does not affect your ability to access it. It doesn't matter. You can access it just the same as you would normally if you were choosing to do so. All right, so now let's do some hand angiograms. We'll just do a little bit of pathology here. So this is the same pathology here and here, and then this is a different pathology here. So orange is the same, different patients, and then red is a different disease process. So this top one here, this one, what we're seeing is occlusion of the ulnar artery at the level of the carpus here with incomplete filling of the superficial palmar arch. Now down here, same, that right there. Now the bottom one, still in the orange, different patient, there is a pseudoaneurysm which is formed at the distal ulnar artery with some distal emboli and abrupt occlusion of the third, fourth, and fifth digits. So we're talking about this. Take a zoom up here. All right. Thing. All right. Now, so both of those processes were affecting the ulnar artery. Okay, so that's a key point. Now let's look over here to this red guy, and you'll notice that there's a bunch of corkscrew collateral vessels. So this is different. So what we've got is corkscrew. See those guys? So this is my strategy for when I get a hand angiogram case. The first thing that I do is I look at the ulnar artery. That's your key. Find your ulnar artery. If it's abnormal, if it's thrombosed, or if there's a pseudoaneurysm, you should think about Hypothener-Hammer syndrome, which is a syndrome that people get when they pound on stuff, hammer stuff, and they traumatize their ulnar artery. Now, if the ulnar artery looks normal, knowing nothing else and not seeing a picture, statistically you're dealing with a Berger's case, because these are the two most common cases shown in case conferences, either Hypothener-Hammer or Berger's. But there is a third thing that can also be shown on a hand angiogram, which is less common, and that is embolic stuff. So Berger's is classically going to have these corkscrew vessels, which is what I showed. But if you've got a bunch of distal emboli and you don't see those corkscrews, it could be some guy with AFib or whatever that's throwing clot. Now the classic history for Hypothener-Hammer is a construction worker, and for Berger's it's a smoker and it's a man. Strong association with smoking for Berger's. So this is what I'm talking about as far as embolic stuff. So we don't see any corkscrew vessels, but we've got this, and we've got our ulnar artery that looks normal, but we're missing vasculature out to the tip of the finger here. So compare this and this to that. This is out, right? This was a guy who had known hypercoagulable state, but it could be from whatever. All right, next case. The purpose of this is we're going to get arterial access on this guy. Looks like somebody already did, but we're gonna get arterial access on this guy. Which one of these places do you want to stick? and why, and doesn't matter. So right here is your ideal spot. Now, you want to be aware of this thing, which is the inguinal ligament, which runs from the anterior superior iliac spine down to the pubic tubercle. So you always want to stick below that. Sticking above that is what people call a high stick, and it makes you susceptible for a retroperitoneal bleed because you can't compress the vessel over the femoral head, which is what you're trying to do. So the ideal spot is a puncture mid-femoral head, which is around 1 to 2 centimeters below. So right there, something like that. Mid to lower 1/3. Gives you something you can compress against. You're not above the inguinal ligament. So if we look at it like this, right there, so coming in at a 45-degree angle, that's what you want. So too high, retroperitoneal bleed. Too low, you can end up with an AV fistula. And then if you stick right at the bifurcation, you risk occluding one of the branching vessels when you put your sheath in. All right, so let's do some vocab. So, what is a French? A French is it's typically a person who surrenders in battle, but it can also be a noun for a third of a millimeter, 0.3. So 3 French is 1 millimeter. Now there's 2 different things you can stick in people's legs. There's catheters and there's sheaths. And what French means is variable depending on which one of these things you're using. So you've got a catheter and a sheath. Catheter, the French, is measured from outer diameter to outer diameter. A sheath, it's measured from inner diameter to inner diameter. Now usually when you stick a sheath in somebody, it causes a hole that's 2 French larger than the measurement for the French. In other words, if this is 10, then it's a 12 French hole, 10 in the middle, 12 total. Now greater than a 10 French sheath, you get a little bit more than 2 extra. But if I was going to remember the thickness, I would just remember 10. So something like this. So this is our femur, this is our femoral head. We're looking at it from the side. This is our vessel running on top of it. So we're going to stick right here, and we're going to get a flash, and then we're going to put a wire down through that thing, right? Pull the needle out. And then we're going to put our sheath in, right? And take the wire out, and then you can put your different kinds of long wires and stuff in there. So how big was the hole? How big is the actual hole? Let's say that we've got a 7 French sheath. Remember, that's a sheath, so that measurement is referring to the inner diameter. So I said earlier that the sheath usually causes 2 French larger hole in the artery. And then, greater than 10, you add a little bit more. So that would be an extra 2 there. So 7 plus 2 is 9. And if 1 French is 0.3 millimeters, then you're looking at a 2.7 millimeter hole. So let's talk about some trivia with regard to blood levels and stuff like that before before it's safe to stick a guy's artery. So you'll want the heparin to be off, and heparin, is one of those things that advantage over IV heparin versus Coumadin is that heparin you can turn off like that quick. So if you stop at 2 hours prior to the study, you're usually in pretty good shape. Coumadin has to be stopped, between 5 and 7 days out. It takes longer, and you want to target your INR about 1.5. Platelets, you need platelets also. They're important. Depending on what you read, greater than 50 or greater than 75 is okay. And Plavix and aspirin, similar to Coumadin, 5 days prior. So after you pull so when can you pull? So that's before your stick. When can you pull? Typically, you're going to want 15 minutes of compression after a pull, and you're going to want an ACT less than 150 or 180. And the heparin can go back on 2 hours afterwards. Now, depending if you're really in a rush and you need to reverse somebody's Coumadin, you can give them vitamin K, IM, 25 to 50 milligrams, or you can go and give them FFP or cryo like immediately prior to the case. Do you need antibiotics before you stick somebody's artery? Not necessarily, at least according to the ACR. It's a clean procedure, so anaphylactic prophylaxis or antibiotic prophylaxis is not necessary. All right, so let's say instead of going to IR, the patient goes to cardiology and gets a groin puncture. So the most common finding after a trip to the cardiologist is this. We've got a classic yin-yang. We've got arterial pulsation here. So this is a pseudoaneurysm. So how do we treat those? There's basically 4 options. If they're small, you can watch them. If they're medium-sized, you can either compress them directly with ultrasound, which is a pain, both for the patient and for the person doing it, if you ever had to do that. It's torture because you have to hold it on there forever. Or you can inject thrombin. And if they're big, and they're too big, like, greater than 3 or greater than 4 centimeters, depending on who you talk to, definitive treatment is surgical. So here's our pseudoaneurysm, and you can do direct compression. If you do direct compression, you want to target it right at the neck. Avoid squeezing the sac. If it's got some clot in it, you squeeze the sac, you can throw that clot all over the place. And it's going to go to the toes, right? This can take up to 20 minutes. It's a huge pain in the ass. Alternatively, you can put some thrombin in there. Now, an important point is you do not want to aspirate. If you do that, you're going to end up just with a big blood clot inside your syringe. You'll put between 500 and 1,000 units in. It's usually just a few cc's. You can't do this if you've got a wide mouth. You don't want to shower this stuff everywhere. It's going to create a bunch of emboli, right? You can't be sticking it if it's infected. Makes sense. You don't operate in a dirty wound bed like that if you can help it. Instrument it. And you're not supposed to mess with it if there's already distal ischemia. All right, so moving on. Let's talk about 2 different kinds of stents. We've got self-expanding stents, and we've got balloon-expanding stents. Some general tips on angioplasty. The balloon should be big enough to take out the stenosis and stretch the artery slightly. The ideal dilation is about 10 to 15% over a normal artery's diameter. Now, you're going to injure this artery, so you want the patient to be anticoagulated because you're going to cause some intimal stretching and tearing. And so you anticoagulate them to avoid thrombosis after this intimal injury, which is going to happen. And typically the rule is 1 to 3 months of antiplatelets, either Plavix or aspirin, following a stent placement. So self-expanding stents are good for superficial locations, anything that's going to be compressed, basically. Anything below the inguinal ligament is a general rule. Or, the carotid also is superficial, right? Now, balloon expandables are better for more accurate placement. They're good in the renals, and there's less chance of migration relative to a self-expanding stent. Now, a balloon expandable stent, if you place that, let's say, someplace where it could get compressed, once it gets compressed down, it's down, right? But the self-expanding one, you can crunch it and it'll come back up. So, just mentioning this stuff again, you want your balloon diameter a little bit larger than the vessel diameter. Some terminology, a 10 by 6 balloon is 10 millimeters by 6 centimeters in length. Millimeters, obviously you're not going to have a 6 centimeter diameter stent, right? That's crazy. The selection size is a little bit longer than the stenosis. You want to cover the entire thing, and a little bit wider than the unstenosed vessel lumen. So let's say you've got a patient who has a proven PE on anticoagulation or a clot in the leg with contraindication to anticoagulation. These are prerequisites for placing an IVC filter. Now, general goal on an IVC filter is to have it be temporary, remove it as soon as possible, usually within 3 months. They'll have a short follow-up to see if they can bring the patient back and get that thing out of there. So where do you place a IVC filter? So the typical position is here, with the tip below the renals. Above the renals has a theoretical risk of renal vein thrombosis, theoretical. Now, your incidence of PE is decreased. That's the point of placing one of these things. But you actually have an increased risk for DVT. And you also have an increased risk for cable thrombosis, which makes sense. The DVT one is the one that sort of counterintuitive, but if you think it through, maybe more intuitive. I mean, your flow through this thing is not going to be normal, right? So maybe a little more turbulent, maybe have a little more stagnation. And if you're high risk already, which is why you're getting this, I think that would probably bias the statistics, but increased risk of DVT. So, clot in the filter is a contraindication to removal. So if you've got clot in your filter here, you'll have to lyse it out before you remove it. Otherwise, you pull that thing and the big clot breaks loose and you get a big PE when the whole point was to stop that from happening. So if you have clot in the renals or you've got clot in a gonadal vein, you'll want to place the filter above that, which makes sense, right? You wouldn't want to. The whole point is to stop the PE, so you got to be in a position to catch that. Another situation is if you've got a circumaortic renal vein, you want to be below the lowest renal vein. So you want to be, if you were above 1, it could maybe go through and around like that, maybe. That's probably never been proven. If you've got a baby in your belly, that's, you want to avoid compression. The IVC is getting compressed by the kid, right? So when you've got a stent in there, that's not good. So then you want to go above that to sort of avoid compression. Or if you've got a weird situation like this where you've got a duplicated IVC. So here you have choices. You can either go above them both, or you can put filters in both iliacs. And the last situation is this. If you've got a gigantic IVC, which has a special name for it. So filters, so this is a so-called mega cava, which is, greater than 28 millimeters. That's the way to remember it. 28 millimeters is a mega cava. And so you can't use a conventional filter. You have to use one of these things called, you can. You can put conventional filters in the iliacs. But the probably classic answer is that you can put a bird's nest filter, which is a different kind of filter that looks like a bird's nest. You can use that all the way up to 40 millimeters. Okay, so that's the end of the this IR talk.